Good afternoon. I'm Apeksha. I'm a senior registrar in dermatology at Teaching Hospital Karapitiya. Today I'll be talking about laser treatment in dermatology. So as we all know, laser stands for light amplification by stimulated emission of radiation. So light is a fundamental form of energy with numerous medical applications. At quantum level, light is composed of packets of energy known as photons. So the energy is carried by each photon is determined by its wavelength, and laser works by pumping many atoms into an excited state, which in turn leads to stimulated emission. This is a diagram illustrating two pathways of photon emission. In stimulated emission of radiation occurs when an incidental photon strikes an atom already in an excited state. So when this atom returns to its ground state, it emits two photons instead of a single photon in spontaneous emission. So moving on to the characteristic features of laser. So the laser light is typically monochromatic, and it shows coherence, and it is also highly collimated. So these properties of laser allows its unique applications in medicine. Moving on to the concept of fractional photothermolysis, it was described by Dr. Mainstein and colleagues in 2004. It has launched another era in laser treatment. So in this method, the patterns of very small non-selective thermal damage zones are used to stimulate the skin remodeling without any scarring. So laser stimulated remodeling is associated with epidermal regeneration, induction of metalloproteases, and also formation of dermal matrix, including elastin and collagen. So this is a diagram illustrating the fractional laser treatment. So a fraction or a portion of the skin is heated in microscopic columns, which are known as the microthermal zones. So the untreated tissues in between the microthermal zones serves as a reservoir for the regeneration of the cells, and this will in turn facilitates the rapid healing. So, in principle, fractional photothermolysis can be applied with wide variety of energy, including non-ablative and ablative lasers. So, currently, even visible light and other technologies such as ultrasound and radio frequency devices have been using these fractionated applicators. In addition to the conventional local thermal destruction, fractionated devices may also help in delivery of drugs into the tissues, as well as extruding materials out of the skin. What happened to the light which is fallen on the skin? So photons can either be absorbed, which are known as transmittance, or it can be reflected or be scattered. The scattering is inversely proportionate to the wavelength, and in such that the shorter wavelengths are scattered more and the longer wavelengths are scattered less. So all these effects of light on the skin begins with photon absorption. So these molecules which absorb photons in the skin are known as chromopores. So what are chromopores? Chromopores are the light-absorbing compounds. So there are few primary chromopores in the skin, such as melanin, oxyhemoglobin, and water. So each of these chromopore has a unique absorption spectrum. Melanin is a commonly used chromopore in dermatology. It absorbs a wavelength of 600 to 1100 nanometers, and whereas water absorbs about 950 nanometers to 11,000 nanometers. Moving on to melanin as a skin chromopore. Melanin absorbs across a wide spectrum of wavelengths. Eumelanin, the primary chromopore in the epidermis, and darkly pigmented hair follicles. It it has a broad spectrum of absorption ranging from ultraviolet light to the near infrared region. So it is also the target laser in hair removal as well as pigmented lesions. And a common mistake is in using these devices for hair removal is using this device for red blonde hair removal because primarily it composed of pheomelanin, and pheomelanin poorly absorbs these wavelengths. Few words about water as a chromophore. So in general, water is not a useful target for selective photothermolysis, as it is abundant in all skin structures. But when it is used in conjunction with appropriate epidermal cooling devices and proper laser parameters, we can use it as an ablative laser we can use ablative lasers for photo rejuvenation. So this wounding of the dermis subsequently results in collagen remodeling and neocollagenogenesis. So more recently, near-infrared lasers have been used to target lipid-rich tissues, and lasers to target lipids are based on vibrational modes of molecules. So lipid molecules are selectively destroyed at 1210 nanometers and 1720 nanometers. So application of these forthcoming devices offer an appealing alternative non-invasive methodology of targeting lipids. A comparison between ablative and non-ablative lasers. So ablative lasers vaporizes the tissues by rapidly boiling water inside the tissue. This is why the ablative lasers are at a wavelength strongly absorbed by water, while non-ablative lasers do not vaporize the tissues and are absorbed by other chromophores such as melanin and hemoglobin. So moving on to the laser dosimetry in ablative lasers. Ablative lasers must deliver about 2,500 joules to raise a local tissue temperature beyond 100 centigrades, which is the boiling point. So not only the energy requirement is high, the energy must be delivered quickly to remove the hot tissues before the heat is conducted deeply into the skin to prevent further burning. So the standard ablative lasers in dermatology are Ebrium and CO2 lasers, and short pulses helps in minimizing the tissue damage. So these are few indications of ablative lasers. So the epidermal disorders such as actinic cheilitis, seborrheic keratosis, and melasma can be treated, and dermal lesions such as benign dermal tumors and scars could be treated. And most importantly, ablative lasers are used in laser resurfacing and in wrinkle reduction and scar treatments. So this is a diagram showing successful treatment of a epidermal nevus with CO2 laser therapy. And so moving on to the laser parameters. So understanding of these laser parameters is quite significant because when we treat our patients, the efficacy is dependent on these parameters. Fluence is defined as the energy delivered per unit of skin area. So it is the local dose of energy applied to the skin. And the pulse duration and pulse width is the length of time the laser beam is in contact with the skin. And power is defined as the rate of energy delivery. Wavelength is dependent on the chromophores in the target structure. And spot size is the diameter of the laser beams on the skin surface. So moving on to the thermal relaxation time. So it is the time taken by a lesion to dissipate 50% of its energy into the surrounding tissue. So laser energy is confined to the target when the laser pulse width is shorter than the thermal relaxation time. This diagram illustrates, so the ideal pulse width is long enough to heat the desired target, while it should be short enough to limit the transfer of the damaging heat to the surrounding tissues. So this concept is termed as selective photothermolysis. This is how the thermal relaxation time varies with the various targets. So melanosomes takes up about 0.25 microseconds, whereas a vessel which is a larger vessel of 0.8 millimeter in diameter will take up about 300 milliseconds. The next point is the depth of penetration. So deep penetration of laser energy is safer for the epidermis. It reduces the superficial absorption of the heat, and also it decreases the epidermal thermal injuries. And sound understanding of these laser parameters allow the applicator to control the laser penetration depth. As shown in this diagram, the long wavelength, long pulse width, and long spot size with a high fluence, the laser waves penetrate deep, and then it prevents the epidermal damage, and it applies vice versa for the superficial penetration. This diagram shows the optical penetration depth of commonly used lasers in dermatology. Ebrium YAG laser is the more superficial, shows a more superficial penetration, while the long pulse ND YAG laser will penetrate deep up to the dermis. I have included two case studies to highlight the importance of these laser parameters. This is a 26-year-old woman with severe scarring after laser tattoo removal done in a locally aesthetic parlor. She recalls she had laser hair removal done by the same operator using same machine with no side effects. However, this time her black tattoo developed blistering and erythema immediately after treatment. Long pulse lasers and IPL emit pulses of milliseconds, and this mainly heats the tattoo skin instead of individual ink particle. Therefore, the pulse duration greatly exceeds the thermal relaxation time of the ink particle. Long pulse sources such as IPL, which is used for laser hair removal, should not be used for treatment of tattoos. The second case study is a 28-year-old man with both nevus of Otta and a dark beard on his face. He wishes a cure from his facial pigmentation. Both nevus and the beard contains high concentrations of melanin. A Q-switch alexandrite laser of 750 nanometers will be highly effective for fading his nevus of Otta. However, the Q-switch alexandrite laser will not permanently remove his hair because its pulse duration is million times shorter than the thermal relaxation time of the terminal hair follicle. This graph illustrates how the laser parameters should be altered according to the patient's and lesional characteristics. Patients with more darker skin types and lesions on non-facial areas with high density intense colored lesions should be treated with a more conservative management with long wavelength, long pulse width, and large spot size with low fluence, whereas lighter skin and face with low density and faint color can be treated with aggressive laser parameters as shown here with a short wavelength, short pulse width, and small spot size with a high fluence. Next we'll talk about cooling, skin cooling. It is mandatory to protect the epidermis and the superficial dermis during selective photothermolysis, and cooling can be applied as pre-cooling or parallel cooling or post-cooling. For epidermis, about 20 to 50 milliseconds is enough, while for both epidermis and dermis, we have to extend it to about 5 to 10 seconds. And pulse duration decides the cooling method. So pulse duration shorter than 5 milliseconds, such as in Q-switch laser. For an example, we can use pre-cooling with cryogen spray cooling as the most appropriate method, while pulse duration, which is more than 5 milliseconds, parallel cooling is the best treatment. And bulk skin cooling is used to minimize the pain, erythema, and edema following the treatment. So there are various skin cooling methods. Direct contact cooling or automated cryogen spray, blow directed cold air, and liquid fluorocarbon spray are used. There are various other methods. So these are few methods that we use in our practice commonly. So few points about Q-switch laser. So we commonly use Q-switch laser to remove tattoos and pigmented lesions. And this laser emits an impressive power of only 10 to 100 nanoseconds. And Q stands for the qualitative factor for light traveling across the laser cavity. And switch means it can be changed suddenly to produce a short, intense burst of light. And dermatological Q-switch lasers are designed to produce pulses of 1 to 100 nanoseconds with fluency of about 10 joules, 2 to 10 joules per square centimeter. And I'll be discussing a few points about laser treatment in vascular lesions and pigmented lesions, and as well as laser hair removal, skin rejuvenation and resurfacing, and also a few points about non-surgical body contouring and laser treatment for ethnic skin. So moving on to vascular lesions. So it is one of the most common indications. So specific lasers are used for specific vascular lesions. Pulse dye laser remains a gold standard treatment for port wine stains, and alexandrite laser is being used for hypertrophic or pulse dye laser resistant port wine stains. And deep penetrating near infrared lasers are used for venous malformations. Vascular lasers and IPL is used for background erythema and telangiectasia and rosacea. Poikiloderma of civet can be successfully with intense pulse light or combination of vascular pigment selective lasers. The principal side effect of laser treatment for vascular lesions is purpura. It is dependent on the pulse duration, fluence, and spot size. And purpura results from microvascular hemorrhage, subsequent thrombosis, and delayed appearance of vasculitis. So this is a picture showing a successful treatment of rosacea with IPL. And few points about port wine stain. So in treating port wine stain, a large spot size is selected to increase the depth of penetration and to minimize the scattering of the light. Proper cooling is essential, and it is important to outline the borders of the port wine stain prior to treatment, because the treatment could blur the margins of the lesion. And long pulse duration and low fluence is preferred in dark skinned patients. And this is a patient who has received alexandrite laser for a hypertrophic port wine stain, and you can see the significant outcome in the second picture. Then a few points about pigmented lesions and tattoos. So the black and blue tattoos are the easiest to fade, while multicolored tattoos are the most difficult to fade. And considering benign lesions, lentigenes are the easiest to treat, and nevi of Ota, Ito, and Hori are the most difficult to treat. So the red near-infrared lasers are most selective, and it penetrates deep. So it is the best best targeting the pigmented cells. And thermal relaxation time of melanosome is about 70 to 250 nanoseconds. So therefore, Q-switch laser remains as an excellent choice of targeting the melanosomes. So Q-switch laser removes tattoo pigments by photoacoustic injuries, and it will break down the ink particles, and later these particles are phagocytosed by macrophages. The lighter skin is better treated compared to the darker skin because the epidermal melanin serves as a competing chromophore with cutaneous lesions for the laser absorption during the treatment. So this will reduce the treatment efficacy as well as it increases the side effect of thermal injuries. And tattoos with white and red ink carries an increased risk of paradoxical darkening after the laser treatment. So it is suggested that a test spot size should be carried out prior to the treatment. And caution should be exercised in treating tattoos which has with an allergic reaction because ink particles can elicit a systemic response. And so pigmented lesions such as melasma and post-inflammatory pigmentation are quite resistant to treatment. So pre-treatment and post-treatment hydroquinone and topical retinoids are advised. And post-operative care, including gentle cleansing and bland emollients, are advised. Various lasers types are used to treat pigmented lesions. So some are pigment non-selective lasers such as carbon dioxide and yttrium YAG lasers, and some are highly pigment selective such as Q-switch ruby lasers and Q-switch alexandrite lasers and ND-YAG and KTP lasers. So this diagram illustrates the common lasers and their depth of penetration. So apart from argon and KTP lasers, which are used in pigmented skin lesions, all the other lasers penetrates to the deep dermis. So the laser choice is based on the tattoo ink. So black, blue, and green tattoo ink is treated with alexandrite ruby and long pulse ND-YAG lasers, whereas red is treated with ND-YAG of 532 and green is treated with ND-YAG of 650. So this is a diagram illustrating a Q-switch ruby laser treatment for a pigmented tattoo, and you can see the successful outcome. And this is a post-inflammatory pigmentation which is treated with the same laser. Moving on to the laser hair removal. So laser hair removal is commonly used in cosmetic procedures as well as medical procedures. So the ideal candidate for laser hair removal is a fair skin with dark terminal hair. However, with the advanced laser parameters, we can use it in all skin types. So ruby, alexandrite, diode, and ND-YAG lasers and IPS sources are used for this purpose. Roughly about 15 to 30% of hair can be removed with each treatment session. And remaining hair often is thinner and lighter in color. And most common complication is pigmented alteration and paradoxical hypertrichosis due to stimulation of the villus to terminal hair transformation is a devastating side effect. So these are few pictures showing how the lasers are used for laser hair removal. And so considering there are various lasers being used for this purpose, and intense pulse light laser has a reduction of about 49 to 100% of hair reduction post-treatment. So few points about skin rejuvenation. Non-ablative fractional laser is the safest and effective treatment for facial rejuvenation, and its efficacy in treating mild to moderate photoaging and fine lines and non-dynamic rhytides and various forms of dyspigmentations. And non-ablative fractional photothermolysis has a minimal downtime, so the patient can resume their activities immediately following treatment. So all skin types could be subjected to these treatment modalities. Erythema and edema are the common sequelae after treatment, and it resolves within few days, and long-term complications are exceedingly rare. And technologies in this field should be individualized, and home-based devices are now available for treatment. So this is a picture of skin rejuvenation. You can see how well it had worked for her. And moving on to the resurfacing, laser resurfacing uses mainly ablative fractional lasers. So pulsed or scanned focus beams are used to precisely vaporize the superficial tissues, causing a plum of material leaving the skin. So most of the heat is removed during the vaporization, and a thin layer of residual thermal damage that is left is used for hemostasis. So most common ablative lasers used in this procedure is carbon dioxide laser and Ibrahimian laser. And laser resurfacing is useful for treating photoaging, acne scars, and various epidermal keratosis and etc. So these are few pictures showing the successful resurfacing. And this is a patient who's been treated with CO2 laser for acne scars. And moving on to body contouring. So the treatment of fat and cellulite is a novel cosmetic procedure. And cellulite is a hormonally based structural phenomena of adipocytes and fibrous septae, whereas excess fat is an overproduction of normal adipocytes. So various treatment modalities are being used for body contouring. So injectable therapies such as mesotherapy and lipolysis, and also the liposuction was the gold standard till quite recent days, and radio frequency devices and high intensity focused ultrasound devices, and laser devices utilizing near infrared wavelengths that are selectively absorbed by adipocytes are in the experimental level. So few points about cryolipolysis. Even though this is not a laser treatment, this is a novel therapy in dermatology. So it uses a controlled cold exposure. It is utilized to selectively damage the adipocytes, which eventually leads to apoptosis, and later gradually improve the appearance and the thickness of the fat layer over several months. And cool sculpting is a relatively novel FDA cleared treatment that utilizes the cryolipolysis technology. So I have included a case study, a 53-year-old female with a normal BMI presenting for a treatment for a small pocket of excessive fat around her abdomen. She is concerned about the risk of invasive surgeries. She doesn't have substantial skin redundancy, and the patient refuses the liposuction, which would have been the ideal treatment modality for her. But she was treated with cool sculpting, and the patient was informed that full effect of the treatment is visible only after 2 to 3 months. So this is a diagram illustrating how the treatment is being done. So there is basically we have to identify the lesion that we are going to treat, and then they create a vacuum and clamp the blood supply and give a treatment session which lasts for about 60 seconds. And you can see the final outcome of fat reduction, which is really successful. And moving on to the ethnic skin and lasers. So the sun protection is essential, and Q switch and long pulse lasers with conservative laser parameters are preferred. And melasma is always a challenge, treatment challenge. And topical bleaching agents should be tried before laser therapy is considered. And non-ablative fractional resurfacing using low density but increasing the number of treatment sessions is recommended for ethnic skin. And this is a diagram illustrating how a melasma is treated with fractional photothermolysis. So post treatment, you can see there's a bit of a dilution of the pigmentation, but however, since it is a dynamic condition, it will regain its color subsequently. A summary of lasers that are used in pigmented skin. So vascular lesions are preferably treated with PDL lasers, and pigmented lesions are treated with Q-switch Nd:YAG lasers, and also the tattoos can be used with the Q-switch Nd:YAG lasers, and also Q-switch alexandrite lasers are used for pigmented lesions and pigmented lesions and tattoos in darkly pigmented patients. And considering photoepilation, best treatment is the long pulse Nd:YAG, but long pulse diode and IPL also can be used in pigmented patients. And resurfacing and ablation, CO2 and Nd:YAG is the best treatment. This concludes my presentation. I wish to thank everybody in the audience and the SLCD for this opportunity. And also I wish to thank my supervising consultant, Dr. Mrs. Binari Vijayanayaka, for her guidance all throughout my career. And also I'm grateful to all my teachers and my colleagues who helped me in my success. Thank you very much.